Asdeep, good evening.
Good evening.
How are
Do
you?
you go for do you go for I'm good, I'm fine. Do you go for Homa score?
Yeah, the Homa.
And how often you're doing it?
No. We never see the dictum is that you should never go for Homa IR to measure the insulin resistance or the sensitivity, whatever it may be. In clinical practice, it has got zero role. It is confined only to the research.
Okay.
Homa IR is never used as a parameter in clinical practice, Rajdeep. It is always the research people only have to go for that.
And same as in the C peptide?
Yeah, C peptide is not to that extent of Homa IR, but C peptide whenever we come across this particular type 1 diabetes mellitus, if you have a suspicion that it is not type 1 diabetes, or you think that it is the type 2 diabetes in the younger, that very recently I had seen a case of 10 years boy with type 2 diabetes. 10-year-old boy weighing around 80 kilos. The class,
Overlapping issues.
yeah, overlapping issues. Or even the LADA also, we go for the GAD antibodies, GAD 65 antibodies.
డిస్కనెక్ట్ అయినట్టు
Rajdeep, am I audible? Talk to your tech team.
ఎస్ సార్ ఇక్కడ ఏమన్నా నెట్వర్క్
Rajdeep,
ఎస్ సార్
yeah. Tell me, Rajdeep. Rajdeep, am I audible?
సార్ సార్ అది మ్యూట్ ఆన్ చేసి సారీ సార్ 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 సార్
Hello, tech team.
Krishna, can you hear me?
Yeah, I can hear you, Rajdeep.
Yeah, you're not visible here. Anyway.
Okay.
I got it. Well, no, see, there's a lot of overlapping in that type 1, type 2 diabetes. Sometimes it becomes really very difficult to differentiate.
Yeah. See, if it is 18 plus, 18 years plus, you more think of type 2 diabetes mellitus, and you ask for the family history of diabetes.
Okay, got it.
Family history of diabetes is definitely present in this particular type 2 diabetes, and the patient will be obese, a rich kid eating fast and junk food, definitely towards type 2 diabetes in the young, whereas an emaciated patient, rundown patient, acutely ill, around 5 to 15 years of the age. Not that below 5 it doesn't happen, above 15 it doesn't happen. So more towards, say when it is acutely ill, it is towards type 1 diabetes. This is clinical assessment. If it is a chronic case, they slowly they putting on weight, and the signs of insulin resistance. Am I audible, Rajdeep?
Yeah, you're visible, but you're not visible.
Acha, you acha.
ఇక్కడ ఏదో డిస్కనెక్ట్ అయినట్టు
Okay. I'm not visible. 1 second. 1 second, please.
Hello, Chaitanya sir, can we close the meeting?
No, you cannot.
నో ప్లీజ్ వెయిట్ అది ఎందుకో మ్యూట్లోకి వచ్చింది సార్ తెలియదు సార్
Yeah. Am I visible, Rajdeep?
Yeah, now you're visible. Yeah.
So slowly developing, and you find the signs of insulin resistance, especially the acanthosis nigricans. The nape of the neck, the flexor extens, the aspects of the forearm and all, and the axillas. Insulin resistance can be made out by these the acanthosis nigricans and the overweight. You find the stretch marks and all. This is probably a case of type 2 diabetes.
One more question.
Yeah, please.
Yes, this presentation is about triple therapy, especially metformin, dapayan.
Forget about the topic.
This is practical clinical question.
Yes, please.
I'm asking you.
Eh.
It's like in Bestia trials talk about metformin, DAPA plus the DPP4 like CETA, right?
Right.
I'm asking you.
Yeah.
If we try to shift over to triple combination in terms of meta plus EMPA plus linagliptin,
Yeah.
what is your take on that?
Yeah, it's supposed to be the best combination on the earth is EMPA, Lina with metformin.
Okay. So
They,
is
see,
there any difference in the outcome of the glucose triad or?
no. See, the only difference is with the linagliptin actually per se. Linagliptin is the real renal gliptin actually, where you can start and you just can leave it just like that without any monitoring, whatever be the EGFR.
That is the main reason because most of the time.
The sitagliptin, if the EGFR goes down, you need to come down from 100 to 50, from 50 to 25. This will not happen with Lina.
That is the reason because
Am I true or not?
yes, it's just this is a practical issue.
Yeah, practical issue. So you start a combination therapy with sitagliptin. Once the patient it is available only with 100 milligram in the FDC. You don't have flexibility. You need to change the combination and you need to write separately the molecules. Suppose it is with EMPA and the Lina. The EMPA and the DAPA, now the cutoff is the EGFR of around 20 is the cutoff.
Yes.
20 ml per minute.
No, yes, that's what I'm asking you. Sometimes we do write about the follow-up for the glycemic KFT and all those. They don't.
Yeah. Without monitoring the electrolytes, without monitoring the RFT, the only drug that can be prescribed happily is this particular, the linagliptin. Linagliptin makes the difference. That is the advantage over sitagliptin and the vildagliptin actually. Even vilda also you have to come down to 50 milligram once a day in the renally compromised patients, Rajdeep.
So, no, what I'm trying to, I know, see, this is clinically becomes very easy. There is no inertia from the patient side, there is no inertia from the doctor side. So, once we start, do you see any difference in this triple combination and what we are recommending? I'm recommending.
See, to tell you very honestly, majority of the doctors who are treating the diabetes segment, especially, they are not going. I have not seen a single prescription of triple drug combination, whatever it may be, either vildagliptin with dapagliflozin or metformin, sitagliptin, dapagliflozin with metformin, and one more has come with linagliptin, the linagliptin and the dapagliflozin and the metformin. I have not seen anybody prescribing this for patients actually. See, this is called the therapeutic inertia, where the doctor knows, knowingly or unknowingly, that is a secondary issue. I am not offending anybody else. I am not shaming anybody else. With due regards to my colleagues, I am telling very honestly that therapeutic inertia is prevailing to the tune of 90% in our country.
Yeah, we know that. Because,
See, we need to break the barriers, Rajdeep. We should be the trendsetters. That's it. Somebody writes or not, that's okay. I can only educate. So far, I'm happy to tell you, Rajdeep, I had finished more than 6,000 speaker programs in my entire career. 6,000 speaker programs. Still, I don't find any change.
so another question, again, practical question.
Yeah.
Do you have any specific benchmark to initiate this triple combination in a named patient or in the patient who has already been in the some monotherapy or the dual therapy?
Yeah, nothing like that. You can just like that. You can start this either with the drug naive patient or the patient who is on a single drug therapy without as far as the SGLT2 is concerned. You never mind about the A1C at all. The baseline A1C may be 7 or 6.5 also, even that time also, you please prescribe add SGLT to metformin. That's what the recommendations say.
Questions.
Only one more. Give me 1 second to finish this. And if you start early in the course of the disease of type 2 diabetes mellitus, then only you will be able to enjoy the benefits of this SGLT2 inhibitors, like the glucose lowering and the blood pressure lowering and the weight reduction and the cardio-renal hepatic continuum. The benefits on the heart, either in the form of 3-point MACE or the heart failure or the heart hospitalization for the heart failure. You start the late, like okay, then after 40 years of duration of diabetes, you start this molecule. It acts only as a glucose lowering agent. It can reduce the fasting plasma glucose and the post glucose, 2-hour post glucose and the this particular the HbA1c, Rasdeep.
Okay.
You want to have all the benefits. You want your patient to enjoy all the benefits. You start it as early as possible. ASAP. The moment the patient comes to you, you don't find any contraindication. You counsel the patient for 5 minutes. What is to be done, what not to be done. You maintain genitourinary hygiene first. You never get dehydrated. Drink plenty of water. Drink plenty of the buttermilk. Drink plenty of lime and lemon water, unless otherwise it is contraindicated. So like that, a lot of fluids intake, like at least 4 liters a day, will never let the down with the dehydration. So as far as this particular genitourinary tract infections or the candidiasis of this particular, the side effects which are common with singly with this, you explain the patient to maintain the genitourinary hygiene, and on top of it you add one linagliptin to this particular empagliflozin or dapagliflozin. The incidence of the bacterial infections and the fungal infections goes down very drastically, Rasdeep. I have told you in every speaker program of mine, I specify this point.
Yeah, you have spoken multiple times about this.
Yeah, multiple times. So because I've seen practically after adding that, so without that I will not prescribe. The triple drug is always metformin, DPP4 and SGLT2. The latest triple drug, not the olden days. That to begin with my lecture, I told you the old one is with the glibenclamide or the gliclazide or the glimepiride with the metformin and the pioglitazone or the rosiglitazone. That was the triple drug therapy.
Last question.
Yeah, why last? So many questions.
The last is like, sir, one of the literature says start this is DAPA versus AMPA. One of the literature says start DAPA A1C is between 8 to 10. Is it true?
See, that is theoretically true. It is theoretically true, but practically, absolutely, it has got no relevance. DAPA and EMPA are one and same.
Yeah, it's a head-to-head.
Head-to-head, the same level of reductions in the A1C, the same level of reductions in the fasting plasma glucose, same level of reductions in the 2-hour post-glucose, Rasdeep. And as far as the complications also, the target organs are concerned, both of them are equally good. That is the reason why US FDA has given approval for this DAPA and EMPA to be used in heart failures in the absence of diabetes, to be used in CKD patients in the absence of diabetes. It is much more better than the RAS blockade, actually. The much more better than the finerenone. The SGLT2 inhibitor is a trustworthy molecule, Rasdeep.
Got it. Right. Thank you.
And that too, you don't need to, as far as the RAS blockade is concerned, either the ACE inhibitors or the ARBs, you need to monitor potassium constantly, because it tends to raise the potassium. And now you know the latest classification of the hyperkalemia. The mild is 5 to 5.5 5, and from 5.5 to 6 is moderate, and above 6 is the severe hyperkalemia. So addition of telmisartan or some kind of certain, let it be olmesartan, whatever be. See, you have to be little bit cautious as far as the renally compromised patients, the accumulation of potassium, the leading to hyperkalemia. Hyperkalemia begets hyperkalemia, and that begets the diabetic kidney disease. Further, it makes it further worse and worse.
So,
But as far as SGLT2 is concerned, you don't need to monitor potassium at all. As far in the case of the progression of CKD, or in the cases of heart failure, you start with 25 milligram of EMPA or 10 milligram of DAPA. You stay, you just keep watching the show, that's all.
got it. So
That is the greatest advantage, Rajdeep.
got it. Thank you. And that means you're given a green approval that we can modify SDR trial, right?
Absolutely.
The sponsor may not be liking this question.
See, I'm sorry, I got these slides by 11:30 or 11:45, and the invitation. The moment I got it, I had sent it to you, Rajdeep. I also totally forgot that we have a session today. I thought it's a holiday for me in the evening, but okay. So that is the reason I was not able to send it earlier, Rajdeep. Because your time is very precious, you cannot allocate your time unless it is informed much in advance.
No, thank you. It was very good. Remember, this is take-home message in SDR trial, plus we can modify yours.
Mesdia trial, yes. You can modify. You are the Jadugar, Rajdeep. You can make many things.
Thank you.
Right? Any questions, please? Yeah. Tech team? Yeah, tech team, shall we wind up this session if there are no questions, please?
Yes, sir. Thanks a lot, sir.
Yeah,
Thank you
please,
so much.
please. Yeah, you can wind up this session, please.